Hi, this is Elliot Fishman, and welcome to part 2 of the role of AI in the detection and management of pancreatic cancer. And I left off with this slide last time, making the point that not only could radiomics be used for early detection, but also for classifying different tumors, perhaps for looking at cystic lesions and determining which ones are potentially malignant, and also for being a prognosis of outcomes, and also choosing what medications, what chemotherapies might be best for a specific patient. We looked at survival of patients with pancreatic cancer with radiomics and published this article several years ago that made the point that radiomic features added to standard clinical features improved prediction of survival in pancreatic cancer. And there have been several articles that have made that point as well. We look at the curves here, again, looking at the radiomics features. Now, obviously, if I see a patient with liver metastasis, they're probably not going to do that well. If there's encasement of a celiac and SMA, I know they're not going to do well. But when you have other patients with a mass that looks resectable, some patients will do great, 12% 5-year survival, but others will have metastasis 5 months later or 3 months later. Yes, there are other things we can look at, CA19-9. There is a whole bunch of different work being done with liquid biopsy. But here you can see that imaging perhaps is an important factor in making these decisions, that we can combine this with other pathologic and genetic biomarkers and perhaps have a really good way of predicting outcome. In this article by Wang, CT-based radiomics analysis based on the whole pancreas can distinguish pancreatic cancers from healthy individuals, and it could potentially become an early tool for pancreatic cancer. Now, this article is not talking about patients who are presenting with pancreatic cancer. This is talking about patients who are often not being evaluated for pancreatic cancer, but it's very early. This article by Wang made the point that CT-based radiomics can distinguish healthy individuals from potential pancreatic cancer cases to be able to detect tumor literally 1 to 3 years before lesions are detected. Work from the Mayo Clinic went further. They looked at radiomics-based models, and they were able to predict cancer up to 36 months prior to clinical diagnosis using radiomics. Even when radiologists looked at the images, they couldn't find a mass present. So now we're talking about a potential diagnosis with substantial lead time. Again, we need prospective validation, but this is very, very important because it changes the way we think about pancreatic cancer and gives us a lot more hope. In that article by Mukherjee in Gastroenterology, talks about the possibility that we're seeing tissue heterogeneity beyond human perception, which I know when I look at a CT, I think I could see everything, but we all know we're not perfect, and computers potentially could see things that we don't see. We can't see some of the textural changes where the tissue looks the same, but computers potentially can, and radiomics is one of those promises. And so again, potential for PDAC detection at a stage when surgical cure is a possibility, this indeed is very exciting. In an article by Rosenthal looking at the work from Mayo Clinic, these findings add to the growing body of evidence that the indirect effects of pancreatic cancer, including endocrine and exocrine dysfunction, and now whole organ radiomic changes, may precede the diagnosis of cancer and could serve as early detection biomarkers. And that indeed is very exciting. The idea about early detection when we're simply screening patients, not just high-risk patients, when we're simply screening, I use the word screening very, very softly. I simply mean that any person over age 40 or age 30 getting a CT scan, perhaps we should look at the pancreas and see what's going on. Now, of course, you want to make sure that you're not overcalling pancreatic cancer, because what do you do? Do you need to do EUS? You're not going to do surgery. Do you need to do biopsy? You're not going to do biopsy if you don't see anything. But again, it'll make us rethink how we do things. Now, when I showed you some of the cinematic rendering and I showed you some of the radiomics, one of the challenges is scan of variability, scan parameter variability, and the reconstruction algorithm used change a lot of the information. And so one of the challenges for radiomics is taking data that works well with one algorithm at one place and bringing in new data and getting the same results. I think we're going to need to work really hard to try to understand this and figure it out if radiomics is going to play a major role. In this article by Motzkowitz, if they are not implemented with the necessary expertise or correct guidance, there is a high risk that incorrect conclusions will be drawn from the work. I think they make the point that radiomics, there are promising results, but there's so much information that's beyond the tip of the iceberg. And I think we're all optimistic, and we are doing lots of work in this area, but we need to recognize some of the challenges. Now, I mentioned the role of AI in pancreatic cancer, from detection to predicting outcomes and everything in between. And articles, I'll just show you some of them. Radiomics analysis between healthy individual and pancreatic carcinoma, predictive modeling, or this article by Zhao, radiomics-based risk score for preoperative estimation of SMV portal vein involvement in pancreatic cancer, or this article by Lee talking about lymph node, detecting positive lymph nodes, which is a critical outcome finding in patients with pancreatic cancer. Again, you have to sample at least 20 nodes at surgery to know if nodes are positive, and size is not always the best criteria. So you can see radiomics has done a lot. One of the things we have done over the last bunch of years is work on using AI for detection of pancreatic cancer. The first thing, of course, is you need to teach the computer how to recognize the pancreas. We did this in part by having the computer recognize multiple different organs and organ systems, and then have the computer do this automatically after we trained it. You can see how nicely you can compare the manual segmentation that we did with what the computer is doing, liver, spleen, stomach, pancreas, and you can see how good the computer can do in terms of predicting the pancreas. And many articles show a very high DIE score approaching 0.9. Another example, once you learn how to recognize organs and recognize normal pancreas, you need to teach the pancreas or teach the computer to see abnormalities in the pancreas. You got to be able to pick up cysts and neuroendocrine tumors and carcinoma, anything that doesn't belong. And you can see you need to be able to do this for smaller tumors. Many different techniques, including a coarse to fine technique, has been used to do this, with the ability, as you can see here, to recognize tumor, recognize pancreatic gland, recognize dilated pancreatic duct. And again, it's this deep network use that people are doing to be able to pick up tumors, and not just large tumors. Here's an example of 3 smaller tumors that can be picked up using these algorithms, right? So again, very, very promising. And again, high DIE score, the ability, as you can see here, going from image to labeling to single phase to multi-phase, the potential for outlining very accurately the pancreas and pancreatic tumor, and this is something which obviously indeed is critical. And as you look at the DIE scores are high, and we're working harder and harder to pick up smaller lesions in that regard. And again, key things we're teaching the computer to pick up smaller tumors is to look at the pancreatic duct, be able to find the duct, look for transition in the duct, and this is a lot of the work we are doing now with Microsoft in what seems to be a very successful algorithm for picking up pancreatic tumors. Now, going back to that point, we need to pick up the tumors we're missing. If you pick up 4-centimeter lesions, the radiologist will see that even on a bad day. It's these 2-centimeter or less tumors that become most important. In this article by Po-Ting Chen, they spoke about looking retrospectively collected contrast-enhanced CT over a 12-year period will compare with individuals with a normal pancreas. They developed an end-to-end tool comprising a segmentation, CNN, and a classifier. The sensitivities of the computer-aided detection and radiologist interpretation were compared, and they had amazingly good results. In a test set of 1,473 real-world studies, the tool was able to distinguish between malignant and control studies in almost 90% sensitivity, 93% specificity, with a sensitivity of 75% for tumors under 2 centimeters. Very, very impressive results. And again, this is the type of work, if it can be repeated, will be very important in improving our ability to detect pancreatic cancer. Now, one thing we're doing also that's critical, I believe, is not just looking at deep learning and not just looking at radiomics, but combining radiomics and deep learning. Perhaps the computer with radiomics will pick up the tumors 3 years earlier, and then deep learning will be trained to be able to find the tumor. That would be very exciting. And again, the combining of both of these can perhaps overcome limitations of either of these. Can 1 + 1 = 3? That's what we're trying to show. Now, another thing that's very important, and with AI pushing the way, is looking at cystic pancreatic lesions. We know that 10% of patients over 60 have a cystic pancreatic lesion. 97% of these are benign, 3% are tumor. But when surgeons and GI docs have patients with cystic pancreatic lesions and they need to make decisions what to do, it's challenging. There was a series of about 850 patients, multiple institutions, top-of-the-line clinicians, yet of all the patients who went to surgery, only 40% had pathology that required surgery. 60% of patients were operated on that didn't need surgery. This COMSIS paper by Bert Vogelstein and his group was able to show that using AI, you can increase the detection of who needs to go to surgery. Instead of being wrong 60% of the time, you were right 60% of the time. And that indeed is very impressive. COMSIS had the potential to reduce patient morbidity and economic costs compared to current state-of-the-art care. We then took this information, looking at what COMSIS learned and how they did it, but used the newest AI algorithms from Microsoft and AI for Good, led by Juan LaVista Ferez, and were able to show with a multi-class approach with the Microsoft boosting machines and programs, we were able to look at the various same cases, same information, no additional information on the lab side, no additional information on the radiology side. We were able to now change the results from this 60% accuracy to an accuracy approaching 90%. We were able to distinguish between IPMNs that could be followed and those that needed to get surgery. We're able to look at not only cancer, but pick up high-grade dysplasia and also pick up early cancers. So this idea of being able to accurately look, and with the transparent models from AI, this is how the parameters were decided, how the patient had or did not have a lesion that needed to be operated on, that is high-grade dysplasia or pancreatic cancer. And our hope is to be able to have this model available where people can simply go in, plug in their data, and come up with predictions on how to manage patients. We have a very important article with significant revisions done in gastroenterology, and we're hoping that these results will be published soon. Now, looking at AI, is it similar to the driverless car where if there's nobody on the road but cars, you'll do well, but if there's people and rain and wind and light and dark, AI may not be as good as you think it is? I think the challenges with AI, reproducibility, Often the studies are designed for a limited problem, but now more of a global problem. Limited data sets that don't have good variability of a population, and unintentional errors in calculations are all problems. AI also, things that are brought up, a liability. Who's responsible for AI making an error? What's the responsibility of the radiologist? What's the responsibility of the health system? Can you blame the computer if you make a decision because the computer said to do it? There's a lot of work that needs to be done. This will enable health practitioners, hopefully, however, if AI does well, to spend more time developing efficient and holistic treatment protocols and will make state-of-the-art diagnostics more affordable. Hopefully, AI can retrain us to do better. Now, I don't think we're looking at a day when AI is going to be by itself. I don't think that day is going to come, maybe someday. You can't predict. But I think AI is to help us detect things, understand things, and help with managing things. It will change how each of the modalities is used. We will talk about new biosensors and biomarkers, new lab tests, and new radiology imaging tests, perhaps some new nuclear medicine type study, or just changes in CT with photon therapy or photon CT to be able to understand tissuing and tissue typing a whole lot better. There's lots of opportunity for changing things. The talk about multi-cancer blood tests, that work is being done by companies like Exact Science and Grail, and it shows a lot of promise. Are we going to be able to screen patients better and screen more patients now, knowing what things are a risk for patients? I think the future is bright. This is an article from a few years ago, literally 9 years ago. It's pretty impressive. Machine learning will displace much of the work of radiologists and pathologists. Radiology is already partway there. Algorithms can replace a second radiologist reading mammography and will soon exceed human accuracy. I think this article about replacing radiologists is a bit much. I don't particularly worry about it, nor do most radiologists, I think. But my answer would be is if the computer was so good it was 100% accurate and they didn't need us, well, we shouldn't be doing it. We need a system that's best for our patients, whether it's the computer or us, but I think it's the combination of the two of us together that really is going to be ideal. In this article by Rebecca Fitzgerald, what the introduction of AI algorithms might do, provided that data management and safety regulations are in place, it is reduce the cost and time needed to diagnose a disease. Furthermore, AI can be a training tool that provides immediate specialist feedback to generalists so that in time they perform at an expert level. One of the big things with AI is, and there have been many articles about this, in many different applications, it takes an average radiologist and makes them an expert. There's significant difference between experts doing pancreas, experts doing breast imaging, experts doing skeletal imaging, and regular radiologists. But what AI can do is make everybody an expert, and that indeed is very exciting. Now, the future is hard to predict, but we know AI is changing everything. And you cannot read a newspaper or magazine and see some of the changes that are rapidly coming. And we're excited about this, and radiologists need to take the lead in doing this. Again, there are problems and there are challenges. There are always problems and challenges. We need to figure out a way of overcoming these problems and challenges and working with companies like Microsoft and Google and NVIDIA, Apple, you name the companies. You can see the ability to use the best and the brightest of computer scientists with the best of people in academic radiology really provides the opportunity to get around these problems. And again, this increased collaboration is critical. The ability to share data, NIH now is requiring on grants that the data be made available to everyone. That's going to be very critical, and that's wonderful use of taxpayers' money. And again, this collaboration cannot be overlooked. Article by Feinberg again. Clinicians think of diagnosis mainly in terms of the detection and classification of disease. Over time, there will be increased understanding. Basically, we're thinking about the future state of health. Interventions may be designed to enhance, maintain, and as needed, restore health. This article and many others like it really take a look at the potential for the future, and it's very exciting. I know as we sit here today and talk, as Donald Rumsfeld said, there are known knowns, things we know. There are also known unknowns, things that we know we don't know. But there are also the unknown unknowns, the ones we don't know. And to me, what's exciting about AI, there's so much that's going to be discovered. These unknown unknowns are really what's going to make the potential for our future to be so good for ourselves and for our patients, most importantly. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.